Hi guys, this video we're gonna talk about the muscles of the shoulder, origin and incision points, functions. We're also gonna talk about the bursae, tendons, ligaments as well. So first, the deltoid is made up of three parts. You got the spinal part, the acromial part, and the clavicle part. The spinal part originates from the spine of the scapula. The acromial part originates from the acromial of the scapula, and the clavicle part originates from the clavicle okay? So all three of these muscles form the deltoid muscle and insert itself at the deltoid tuberosity of the humerus. Now, first muscle we're going to talk about is the subscapularis. Now, the subscapularis is a muscle that originates from the subscapularis fascia in front of the scapula, so more on the anterior side. It inserts itself at the lesser tubercle and crest of the humerus. Function of this muscle is to provide adaptation and internal rotation of the arm. Next is the supraspinatus. Now, the supraspinatus muscle is a muscle that originates from the supraspinatus fascia of the scapula, and it inserts itself at the greater tubercle of the humerus. Function of this muscle is to provide abduction. Next muscle is the infraspinatus. The infraspinatus is a muscle that originates at the infraspinatus fascia. It inserts itself at the greater tubercle of the humerus. Function of this muscle is to provide external rotation. Next muscle is the teres minor. The teres minor is a muscle that originates at the lateral border of the scapula, inserting itself at the greater tubercle of the humerus. Function of this muscle is to provide external rotation and extension of the arm. Next is the teres major. The teres major originates from the inferior angle of the scapula. It inserts itself at the crest of the lesser tubercle and humerus. Function of this muscle is to provide adaptation, extension, and internal rotation. Now, the rotator cuff muscles is made up of the subscapularis, the teres minor, the supraspinatus, and the infraspinatus. All of these muscles support each other to stabilize the shoulder. Now, importance of clinical anatomy is that some people can have rotator cuff tears, tendonitis, which means inflammation of the tendon, bursitis means inflammation of the bursae. Now moving on to the real anatomy of the shoulder. We're going to do a very deep dive into the shoulder. Now, the shoulder joint is formed when the head of the humerus joins with the glenoid fascia. But the problem is the head of the humerus is actually much larger than the glenoid fascia itself. So it is good for range of motion, but bad for stability. So around the glenoid fascia, there is this fibrocartilaginous ring called the glenoid labrium. This deepens it slightly, increasing the surface area for about 50%. So it has more of a stable way of supporting the shoulder. Now, surrounding the shoulder, right, there is this synovial membrane. Now, this synovial membrane contains synovial fluid, which acts as a lubricant, lubricating the joint, reducing friction in between the glenoid fascia and the head of the humerus. It also nourishes the cartilage, meaning it provides healthier and strengthens the cartilage as well. Now, we have three ligaments at the anterior part of the shoulder. First is the superior gluteal humeral ligament, the middle glenoid humeral ligament, and the inferior glenoid humeral ligament. Now, the superior glenoid humeral ligament provides stability for the shoulder. The middle glenoid humeral ligament is sometimes absent in some people, meaning that it doesn't exist in some people. I'm not saying that it exists in all people, but some. And next, which is the inferior glenoid humeral ligament. Now, this ligament is the strongest and the most important stabilizer. Why? It's actually because it prevents the shoulder from dislocating anteriorly. There's also a ligament called the coracohumeral ligament. The coracohumeral ligament originates at the lateral border of the coronoid process, and it blends together with the superior capsule and the supraspinatus tendon. It provides stability and limits the range of rotation as well, so that your shoulder doesn't rotate too far out. Now, we also have two ligaments here called the transverse humeral ligament and the coracoacromial ligament. Now, the transverse humeral ligament goes over the intertubercular groove and holds the long head, the bicep tendon in place. Now, without the transverse humeral ligament, the long head, the bicep tendon could dislocate medially. Next, we have the coracoacromial ligament. Now, the coracoacromial ligament prevents the head of the humerus from dislocating superiorly. It is part of the subarachnoidal space, and when it gets tight right, it can cause subarachnoidal impingement syndrome. Why this happens is because some of the structures, such as the subarachnoidal bursae or the supraspinatus tendon, is getting compressed. Now, there is a layer on top of the ligaments called the fibrillous layer. It is a tough layer that encloses the joint together. Okay, it attaches to the anatomical neck of the humerus and the margins of the glenoid cavity. It blends together with the periosseum, provides strength and support, and resists dislocating and anchors the joint in place. Now, below the fibrillous layer, there is this thing called the axillary recess. Now, the axillary recess is a pouch-like extension of the capsule itself. It allows the head of the humerus to glide downwards, and in common conditions like frozen shoulder, this can actually get fibrocortic and contracted, meaning that it actually resists range of motion as well. So you have a loss of range of motion because of the axillary recess being fibrocortic and contracted. Now, clinically, the rotator cuff is one of the most common sources of shoulder pathology. The most common injured muscle is the supraspinatus tendon. It could be due to frequent injuries such as impingement syndrome under the acromial, or it could be due to age-related tendon degeneration. Any other rotator cuff injuries can cause a limit of range of motion, weakness, stability problems, and pain. Now, there are a lot of bursae around the shoulders, and we're going to first talk about 6 of them. First, we have the subdeltoid bursae. The subdeltoid bursae is a bursae between the deltoid muscle and the joint cavity. Next, we have the subarachnoidal bursae. The subarachnoidal bursae is between the acromial process and the supraspinatus tendon. Now, the subarachnoidal bursae and the subdeltoid bursae are the most common bursae for impingement syndromes. Next, we have the subtendinosus bursae of the teres major muscle. This allows the friction being reduced as the muscle glides over the head of the humerus. We also have bursae such as the coracobrachialis bursae, which cushions the coracobrachialis muscle. We also have the coracoclavicle bursae, which lies between the coronoid process and the clavicle. Now, the coracoclavicular bursae often gets inflamed due to overhead repetitive movement, like overhead activities. Lastly, we have the subcutaneous acromial bursae. Now, this bursae is found just under the skin, above the coronoid process, and it helps to move the skin during overhead elevation or loaded weight-bearing exercise. Lastly, we have the transverse humeral ligament. Like we talked about it, the intertubercle tendon sheath wraps around the long head of the bicep tendon, and like I said, without the transverse humeral ligament, they could dislocate the long head of the bicep tendon So yes, that is all for today. Thank you very much for watching this video.